Okay, so first of all, we're going to cover principles of patient selection and highlight some changes in this area. The biggest change is, believe it or not, you do not need to have type 1 diabetes to be listed for a pancreas transplant. Used to be that that was essentially a requirement for this, but the fact of the matter is that there are a lot of pancreases that are discarded, and so there is, in many ways, no shortage of pancreas transplants. And so UNOS has tried to break down any obstacles to pancreas transplants when it is felt that this could benefit patients. And it turns out that pancreas transplants can benefit even some type 2 diabetics. Okay. So again, prior to 2019, there was a requirement for a documented low C-peptide level, which implies again that this is a type 1 diabetic. Um, and then there was also sort of an allowance for certain non-insulin resistant type 2 diabetics. Okay, so type 2 diabetics who were non-insulin resistant were captured by this lower BMI and then lower insulin requirement criteria. Now, these criteria are also not even in place. So each center can decide who they want to list for a pancreas transplant. Okay. In general, we have most patients undergoing simultaneous pancreas kidney transplant. Obviously, this means it's from a deceased donor. However, there are certain patients that can undergo pancreas after kidney transplant. Many of these are patients that undergo living donor transplants of the kidney and then a cadaveric pancreas transplant after a living donor transplant. And it's a minority of patients that is receiving only pancreas transplant that would be specifically to treat, in most cases, type 1 diabetics, right? With multiple complications from their diabetes, such as hypoglycemic unawareness. That would be a classic instance in which you're thinking about, not even using insulin pumps, but doing a pancreas transplant in a type 1 diabetic alone. So the ideal candidate is a patient that is relatively young and without coronary artery disease. This second point deserves a special clarification. It turns out that outcomes after pancreas transplants were pretty poor in those individuals that had, let's call it, clinically significant coronary artery disease, right? History of myocardial infarctions, for instance, or complex CAD requiring multiple PCIs. And so this was baked in to the criteria for pancreas transplant listing now. In most centers, if you have, let's call it, meaningful CAD, you are deemed not a candidate for listing for pancreas transplant. That is based on historic data that shows inferior outcomes, significantly inferior outcomes in patients listed for pancreas transplant. Now, you may still consider listing some of these patients for kidney alone, so that you may have CAD and still be deemed a candidate for kidney alone, but not for pancreas and kidney. So know that there is a bit of nuance there, that there's more rigor in restricting pancreas transplant for CAD compared to restricting kidney alone for CAD. Okay. And here is some of that data. Again, older patients do have a higher risk of graft loss as well as an increased risk of death. And then I've mentioned, again, some of these patients with more clinically significant CAD, they have a higher mortality. You can see a 20% mortality in those patients with a myocardial infarction or coronary revascularization when you undergo pancreas transplant. Okay. Now, again, most people are simultaneous kidney pancreas, that's SPK, but there are individuals who undergo pancreas after transplant, pancreas after kidney, and again, those would be most commonly living donor transplants that want a pancreas donor, a pancreas transplant after kidney transplantation. Okay, deceased donor pancreas transplant waiting times are very short in comparison to kidney transplant waiting times. So, and that could be on the order of months. Okay, and so again, some individuals are electing for this shorter track of undergoing living donor transplant as opposed to waiting for simultaneous pancreas kidney transplant, even though that individual in general has a lower wait time. So SPKs do generally have a lower wait time than patients who are waiting for kidney transplant alone. Okay. Um, so let's go on to outcomes. Patient survival for patients that undergo SPKs, that simultaneous kidney pancreas transplants, do seem to have comparable outcomes to individuals that have a living donor kidney transplant alone, but this is better than those patients that are undergoing deceased donor kidney transplants. Okay, so it is because pancreas transplant mortality post-transplantation is a bit higher, right? These patients come in with a higher comorbidity, list of comorbidities, and then the pancreas transplant is a more complex surgery. It requires heavier immunosuppression. And so that explains why simultaneous kidney transplants, simultaneous kidney pancreas transplants, um, are going to have a higher risk than some patients that are just undergoing, living donor kidney transplants. You would think that um, these individuals would have some additional survival advantage by undergoing the pancreas transplant, but it is a more complex surgery with more perioperative complications. Okay, here are some of those perioperative complications: a not insignificant risk of early graft loss. Often these are vascular complications. In fact, there are many institutions that perform pancreas transplants that, as a routine, put people on anticoagulation shortly after the surgery takes place. For instance, lower dose heparin is a protocol that I had experienced when I was in fellowship in patients that underwent pancreas transplants. There is an increased risk of DVT. There's an increased risk of fungal infections. Once again, the immunosuppression for a pancreas transplant is more intense than that of a kidney transplant alone. Now, in general, simultaneous kidney pancreas transplants will have signs of rejection in both the kidney and pancreas simultaneously. Okay. And that makes sense because the donor is the same for both pancreas and kidney in these simultaneous transplants. And so the kidney serves as an early sign of pancreas rejection. So pancreas rejection, you don't have a serum creatinine to monitor pancreas rejections. We sometimes are looking at serum amylase or lipase. We are also looking at worsening glycemic control as a sign of pancreas rejection, but those are fairly insensitive when compared to an increase in serum creatinine. So many times, again, the early warning of pancreas rejection is that I'm rejecting my kidney. Okay. And so again, worsening glycemic control or increase in pancreatic enzymes is going to be a insensitive or later stage sign of allograft failure, pancreas allograft failure. Okay. You can perform pancreas biopsies looking for rejection. However, that's much more complicated than doing a kidney transplant biopsy. And the pathology interpretation is also more complicated. So we don't have, clear, like, well-studied Banff criteria, reproducible Banff criteria for rejection as we do for the kidney transplants when compared to pancreas transplant pathology. That is a much less developed field than that of kidney transplant pathology. Okay. In general, these days, the pancreas exocrine gland is drained into a loop of bowel. It used to be that pancreatic ducts were drained into the bladder by some institutions. The thought was that you could monitor urinary pancreatic enzymes as one way to assess allograft dysfunction, pancreatic allograft dysfunction. However, these individuals would have bicarbonate wasting and could get volume depleted by this exocrine gland dumping into the bladder. That could also predispose to UTIs. So again, most centers that are doing pancreas transplants now drain the exocrine gland into a loop of bowel so that that bicarbonate is reabsorbed as opposed to leaving the body. Okay. Again, more potent immunosuppression is required because the rates of rejection in general are higher. What is the consequence of a pancreas transplant that is successful? In general, we get essentially normalization of glycemic control, lipids improve, the hypoglycemic unawareness tends to get better. You can have stabilization in neuropathic symptoms, and that may even translate to improved life expectancy in those individuals who have profound autonomic insufficiency. We get stabilization of retinopathy. So those are some of the advantages of undergoing pancreas transplant beyond simply the better quality of life from not having to monitor blood sugars and adjust diet so carefully. Okay. Rarely, centers will perform so-called islet cell transplants. This has, dramatically fallen out of favor these days. This was an old strategy that was pursued where islet cells were procured from multiple donors and would be injected into the portal vein. And some of those islet cells would engraft into the liver and start to produce insulin. However, the problem was that that could sensitize the individual because you had to use multiple donors in order to procure sufficient islet cells to achieve that insulin dependence in a only proportion of patients. It was less predictable that that strategy would actually work. And so islet cell transplantation really is mostly a thing of the past. All right. Let's go over, if there's no questions about islet or pancreas transplantation, let's talk about renal dysfunction when other organs are transplanted. Most commonly heart and liver and lung transplants recipients, they can develop meaningful kidney disease. And so let's take on that topic in this section here. Okay. So calcineurin inhibitor toxicity is the main driver of this allograft or this kidney dysfunction or CKD in patients that are undergoing non-renal transplant. Some of them also have pre-transplant CKD. It is of no surprise that those patients that undergo heart transplants in particular have some of the same CKD risk factors, hypertension and diabetes, that our renal transplant recipients have. And so, especially those patients with heart failure are a patient population that has pre-existing CKD. So when those two overlap, pre-existing CKD and calcineurin inhibitor therapy, it stands to reason that that CKD can progress and become clinically significant later in the life of the transplant, of the heart transplant recipient. Okay? Acute renal failure from things such as acute calcineurin inhibitor toxicity or the stress of surgery perioperatively. Those can be predisposing factors. And of course, these individuals that are receiving other organ transplants are also developing post-transplant diabetes that are predisposing to CKD later in the recipient's lifespan. Okay? So there are some data that are out there that predict the rates of clinically significant CKD. Clinically significant CKD in this definition was stage 4 and 5 CKD after non-renal transplantation is estimated at 25%. This comes from a classic New England Journal paper looking at clinically significant CKD risks and patients that were recipients of intestinal transplants. Those individuals are typically heavily immunosuppressed because that transplant population, although rare, is a group that is predisposed to rejection. They require heavy immunosuppression. 20% for liver transplant recipients. Again, liver transplant recipients are in general going to have lower immunosuppression, total immunosuppression. So why is this a particularly high risk patient population? Well, it's because in the age of this publication, liver transplant recipients were commonly entering the transplant phase with hepatorenal syndrome. So many of these individuals were even in dialysis-dependent renal failure at the time of transplantation, and a significant proportion of those individuals were developing, let's say, advanced CKD post-transplant or essentially ESRD with non-recovery of renal function. So you got a good 20% of those at 6 years that were developing advanced CKD, including ESRD. Okay, so again, that is spelt out in this note here. Again, that hepatorenal syndrome peri-transplant is the explanation for these higher rates of CKD in the liver transplant patient. Lung transplant recipients had a rate of around 15 to 20% and 10% for heart transplant recipients. Okay. Now, we do have formal criteria for dual organ listing now. It used to be a very variable landscape. There were some centers that were very aggressive at doing combined, for instance, liver kidney transplants, heart kidney transplants, or this should say, just noticing that, lung transplant, lung kidney transplants, okay? There are now, again, standard criteria across all of these three: liver kidney, heart kidney, and it should say lung kidney transplant. I'm seeing yet another mistake there. One day we'll get them all out. These are the broad strokes, and they're generally aligned across these three domains. In general, you'll need CKD defined as a GFR of less than 60 mils per minute for at least 90 days, okay? And you must have a GFR of less than 30 at the time of listing. Okay, so CKD, You can have a GFR of 59 for at least 3 months. And then at the time of listing, you have sort of acute on chronic renal insufficiency where GFR is less than 30 mils per minute. That would be one criteria that will buy dual listing for liver kidney, heart kidney, or lung kidney. Or if you have AKI for at least 6 weeks. AKI defined as GFR less than 25 mils per minute. Okay. Now, for liver kidney alone, there are these special criteria that exist, including this primary hyperoxaluria, because you can essentially cure individuals of primary hyperoxaluria by doing a liver transplant. This would be an indication for liver kidney transplant. Perhaps this story will change now that we have a antisense RNA that allows us to effectively treat primary hyperoxaluria. But for now, again, this would be an indication for dual organ listing. If I have a cause of hemolytic uremic syndrome that is from a mutation in a hepatically derived complement regulatory protein, the classic one being factor H, that would also be a scenario in which liver kidney transplant would be considered. Now we have some other more kind of esoteric things when we have amyloidosis derived from a hepatically produced protein, and then this methylmalonic aciduria would also be cured from a liver kidney transplant. We will also sometimes perform liver kidney transplant on a case-by-case basis in patients that have PKD, who have complications related to liver involvement from PKD. That can include portal hypertension, that can include massive hepatic enlargement causing malnutrition. So those would be exceptional cases in the PKD landscape where you can perform combined liver kidney transplant. Okay. Now, there is this policy now because there's more formal criteria. What we don't want is, again, a lot of liver transplant or heart transplant or lung transplant recipients having ESRD within the first year of receiving a transplant. That would be a patient that will do very poorly post-transplant. If you're on dialysis, that would be a bad outcome. And so there is a safety net protocol to avoid that outcome. You've made a huge investment by taking an organ out of the donor pool, putting it into a recipient. Now you want to maximize the good. Maximized good would be that individual surviving for a long period of time, and getting them off dialysis would be a way to do that. Okay, so the safety net is basically when an individual who undergoes a liver, heart, or lung transplant alone, if they develop a GFR less than 20 after transplant within the first year, then they would be able to be listed for a kidney transplant and prioritized on the wait list. So they get ahead of most other people, except for really highly sensitized or zero antigen mismatched candidates. They jump to the front of the line in order to shorten their wait time and get them off dialysis. Okay, that is the so-called safety net listing for a kidney transplant when you undergo a liver, heart, or lung transplant alone. Okay. Questions about renal impairment post-transplant?